Okay, so we've just summarized the use of beta blockers in the context of heart failure. And now we're going to talk about a special type of beta blocker, the mixed-acting beta antagonists. And so these have affinity for beta 1, alpha 1, and in some cases beta 2, but really for the context of this lecture, we'll focus on beta 1 and alpha 1. And that drug is carvedilol. So carvedilol has, as I said, it has mixed-acting antagonist activity, and the beta to alpha blocking ratio is nearly 10 to 1. So that's about 10 beta receptors, beta 1 receptor, for every 1 alpha 1 receptor. And clinically, it's used for hypertension, heart failure, AFib, and angina, reduced left ventricle ejection fraction, and myocardial infarcts. And so relatively a great drug with lots of disease indications. And the trials that reported the beneficial effects of carvedilol include MOCA and PRECISE, and those trials can be found summarized in the literature. So understand that we talked about beta 1 and its ability to control things like heart rate, contractility, and so forth. Let's review a little bit about what alpha 1 does in the periphery. And so understand that within the vascular smooth muscle and surrounding blood vessels, we're looking at alpha 1 as the primary constrictor. Okay, and so that's across different vessels throughout the body. And so alpha 1 is primarily the constrictor, and beta 2 is primarily the dilator. Okay, and so that's kind of unique because in other examples through the body, we have sympathetic stimulation producing one effect and parasympathetic stimulation producing the opposite effect. And so that really only kind of exists in a special case within the skeletal muscle, but understand primarily that the majority of vasoconstriction and vasodilation is through sympathetic nerve stimulation. So this is through norepinephrine or epinephrine hitting either alpha 1, in some cases alpha 2, and beta 2 receptors. Okay, so this is just kind of comparing what's happening in terms of the cardiac myocyte with the vascular smooth muscle. So in the cardiac myocyte, you've got norepinephrine basically producing an influx of calcium, promoting contraction. In the vascular smooth muscle, you've got norepinephrine or epinephrine hitting the alpha 1 receptor. Okay, and now this is a different signaling transduction pathway, but at the end the concept is the same. You've got more calcium, okay, being available for a more intense contraction or vasoconstriction, and this is typically seen in periods of stress. Okay, but why would we see two different outcomes when the same endogenous ligand, epi or norepi, can produce two different processes? And so this, I really like this diagram. I think this puts things into perspective. If you think about beta 2 receptors promoting vasodilation or relaxation, and alpha 1 receptors promoting vasoconstriction. And so, basically what we're looking at is the flight or fight response. And this is overly dramatized by a kid who's in school, bored out of his mind, and a tiger chasing you through the jungle. And so this is kind of our rest and digest physiology right here. So at low epinephrine concentrations, okay, the beta 2 receptor is occupied because these receptors have a much higher affinity for epinephrine, right? And so as you're just sitting there, you have vasodilation, and your beta 2 receptors are binding to the epinephrine because of their high affinity, and they're promoting vasodilation. Now, when you're stressed, when you see a tiger coming out of the forest and it wants to eat you, that's a stress response. And so now here you've got much higher epinephrine concentrations because you're scared. And now, even though the affinity for epinephrine in terms of alpha 1 is much lower, all the beta 2 receptors are currently occupied by all this excess epinephrine, which means now epinephrine can slide over and bind to the alpha 1 receptor. Well, because of the number of alpha-1 receptors, note there's more alpha-1 than beta-2, more in number, there's a more intense vasoconstrictor response or a contractor response. And so during periods of stress, even though beta-2 is bound heavily by epinephrine, the resulting net outcome is a vasoconstrictor response, because here you've got large numbers of alpha-1 receptors being bound to all this excess epinephrine floating around. So this is, I really like this in terms of the normal physiology, in terms of the flight or fight response. But when you combine a drug like carvedilol, okay, which is beta-1 and alpha-1 inhibitory, you actually inhibit the contractor response and you promote relaxation through the use of this drug. And so remember, the beta-1 response is primarily on the heart. Now we're inhibiting the alpha-1 response, which is in the vascular bed. And so we're inhibiting kind of the contractor response, and we're promoting more of the relaxation response through the use of these beta-1, alpha-1 mixed acting antagonists. Okay, and so the history of beta blockers and heart failure is pretty interesting. There's a nice link here at the bottom. But for years, the main therapies were two drugs we haven't talked about yet, digitalis and diuretics, and they were the main drugs for heart failure. And with these two drugs, patients very rarely lived for more than a few years with heart failure. The mortality rates for heart failure back then were much, much higher than they are now. And in fact, beta blockers were actually contraindicated in the 70s and 80s because it was well known that they reduced cardiac output. And so in patients that have heart failure, reducing cardiac output just seemed counterintuitive. That viewpoint, that rationale was replaced in the 1990s as small clinical trials became more and more published, showing that actually, these drugs are not unacceptable, they're quite plausible. And so this is just kind of one example. We actually see a change in left ventricular ejection fraction over 6 months of therapy in patients with carvedilol. And look at this, over 6 months, based on the dose that patients are given, there's actually an increase in terms of the left ventricular ejection fraction, in spite of its inhibitory effect on cardiac output. Okay, and so the analogy here is that in the heart failure patient, the heart is ailing, and it's almost like you're supplying a beta blocker which acts like a cast. So if in case like you have a broken bone in your foot or your arm or something, you immobilize the broken body part in a cast. The beta blocker actually acts like a cast and basically kind of keeps the heart in a lower state of work than what it's typically used to, which allows it to heal and regenerate part of itself. And so that's kind of the concept, if you think about it, in terms of why beta blockers are so useful in these cardiac pathologies, is that they keep the heart in a rested state so that it can essentially heal itself, and then over time the heart will return to essentially near normal levels of cardiac output, in spite of the beta blocker being on board for 6, 8, 12 months, something like that. Okay, so of course there are some guidelines and rules for the use of beta blockers. You definitely want to avoid them in patients that have asthma, so the non-specific beta blockers like pinolol and propanolol and so forth. You want to avoid using beta blockers when the heart rate falls to less than 50 beats per minute, and you want to use them avoid using them in second and third degree heart block. And so we'll learn about more about second and third degree heart block in the arrhythmics lectures coming up, but those are just some kind of general guidelines to avoid using beta blockers. You would use beta blockers with caution in advanced stages of heart failure, or where there's an acute exacerbation or worsening of heart failure. And of course, when the heart rate falls to less than 60 beats per minute, or systolic pressure falls to less than 90 millimeters per mercury. Side effects, the main one that you should be aware of is an abrupt withdrawal. So if patients forget their medicine or if they suddenly stop taking it, you can get a tachycardia, and that can be accompanied by sudden cardiac death. Weight gain, hyperkalemia, depression, fatigue, loss of sexual interest, and alterations in lipid metabolism are all well-known and well-described side effects to beta blocker therapy.